nutritionist at Henry Ford Hospital in Detroit. I'm going to talk to you a little bit about Fresh Prescription, which is a program that we piloted in our Detroit facility. So we had a pretty overwhelming problem. I know a lot of you are familiar, about 70% of the general population of the United States is obese, but specifically in Detroit, about 31% of the population is obese. Many of the Detroit residents have a lot of barriers to healthy eating. One of these is just a lack of basic nutritional knowledge. We also have limited access to fresh foods, and all of this can contribute to many chronic diseases that are obesity related. By improving nutrition, we do have a major health implications with this. About 7 out of every 10 deaths in the United States are caused by chronic diseases that can be improved by diet. So I know we've talked a lot already in this conference about some of the costs related to these chronic conditions. Heart disease costs about $190 billion for the healthcare system per year. Diabetes is even higher at $245 billion per year, and obesity costs the healthcare system about $147 billion per year. So the Fresh Prescription program was launched by the Ecology Center in 2013. It was first piloted at Henry Ford in 2015, and the program has been running with the formal intervention from 2016 through 2019. So the goal of the program is basically to improve nutrition knowledge and access to fresh food in Detroit. We have pretty broad enrollment criteria as of now. The patients just have to be seen in our internal medicine clinic, have a BMI over 25, and be motivated to improve their diet. So we have 3 parts to the intervention. The first one is nutrition education. We played around with the amount of education sessions over the last 5 years, trying to find what works well for our program and what works well with our funding. So in the past, we've had anywhere between 4 and 8 sessions. Our current year right now has 6 nutrition sessions. This can be phone sessions that they do with a registered dietitian. It can be done in person at the farmer's market, and it can be done through things like cooking demos. The other thing is that after the patients complete their nutrition education counseling session, they get money loaded onto a reloadable debit card. We've also played around with the amount that we've given, again, based on our funding. We've had anywhere between $10 and $15 for each educational session. After this, they can use that money to at many of the farmers markets in the city. Most notably, Eastern Market is one of our biggest partners right now. After the patients have completed the program, which includes 12-week follow-up for biometrics like weight, A1Cs, and blood pressure, they are eligible for another $20 bonus box that can be delivered to their home. The other thing that we kind of do on the side is we give a little bit of financial resource counseling. Pretty much just includes informing people of things like double up food bucks and SNAP benefits, so that that $10 or $15 that they get can be stretched so that they can actually get a good amount of fruits and vegetables with this. So the way that we measure our success, we do have a pre and a post survey, as well as measurements of biometrics, which include weight, blood pressure, and A1Cs for pre-diabetics and diabetics. So over the last few years, we have had a steady improvement in referrals and enrollments. This is primarily due to increase in physician engagement and increase in the participant engagement, as well as an improvement in workflow as we've integrated it into our clinic. So here's a general graph of the way that our referrals have been going. So you can see year 1 to year 5, we had an increase in referrals and enrollments. We did have a little bit of a dip during last year's program. But overall, we've had a general increase. Our first year, we had about 8 enrollments. This last year that just finished up, we have 97 enrollments. So we've had a pretty good increase in our rates. So I want to just highlight one year to show you guys kind of how our results are from our participants. Year 3 is the most complete year of data, so that's why I chose that one. So this is kind of just an example of how the breakdown usually happens. So during this year, we had 211 provider referrals, which just means that either a resident or a staff physician will send over the chart so that we can contact the patient. Out of these, 73 of those patients were actually enrolled. Enrollment means that they come on a Friday, they meet with our coordinator, fill out some paperwork, do the pre-survey, meet with our dietitian at the market, and then go down to the market at the same time. So we do have an actual on-site market during that day. So out of those 73 patients, 43 participants actually completed the entire program. 30 did not complete it, which gives us an N of 43 with a 35% enrollment rate and a 59% completion rate. And that has been steady over all of our years so far. Kind of a breakdown of the kind of participants, just we are a Detroit facility. Most of our participants are female. Most of them are African American, and most of them have a salary that is less than $35,000. So from our pre and post survey results, we get a lot of good information from our patients. During this year, 70% of the participants reported an increase in the amount of fruits and vegetables consumed, with an average increase of 1.36 cups per day. 60% reported a decrease in the amount of unhealthy items consumed, which is, chips, things like that. That's an average decrease of 1 unhealthy item per day. And then 58% reported a decrease in sugary beverages consumed. 79% reported that they are better able to manage their health conditions, and this has a lot to do with our registered dietitians. They're really good at kind of catering their information towards any conditions that the patients might have. And then 100% of participants did report an improvement in nutrition knowledge after completing the program. So we do also follow up on biometric data that's including weight, blood pressure, and A1Cs for pre-diabetics and diabetics. Out of the 43 participants, 28 returned for the 12-week follow-up. And the reason why we chose 12 weeks is that's how long it takes usually for an A1C in a diabetic to change or to kind of flip over. So we thought it would be a good range for the patients to come in. Out of the 28 that returned, 13 had weight loss, and the average weight loss was 8.3 pounds. 9 had improvement in blood pressure. So altogether for our outcomes so far, what we've seen with the program is an improvement in nutritional knowledge, an increase in fruit and vegetable consumption, and a decrease in unhealthy items. So we do have a specific story that from our past year, we had a patient who had severe lung disease and who had completed an entire workup for a lung transplant, but she didn't actually meet the BMI criteria. So there's a certain weight limit that they can do the transplant. So she did the program 2 years in a row with a Cooking Matters lesson in the middle, and she lost enough weight to actually qualify. Now she's listed for a lung transplant. So for the discussion, we all know that fruit and vegetable intake is related to healthy eating habits and can help prevent or improve many chronic diseases, and that's really what our focus is running through an internal medicine clinic. Chad's Clinic in Detroit is one of our other sites because this is a program that runs at different markets. They actually showed an improvement in A1C that was statistically significant in their diabetic population. Year 5, that's our current year right now. We are largely funded by an Eastern Market grant. In the past, we've been funded by things like an endowed chair fund from Dr. Wisdom, who's our PI. As well as some SNAP benefits, and then there's programs from our hospital, and even the graduate medical education has given us grants as well. This has been our highest enrollment so far, and it's probably because we've expanded it to get referrals from other departments too. We have had some increased participants and an increase in walk-in referrals, mostly because we had a little spot on Channel 4 News, and then people started calling the clinic after that. We do still have a lot of barriers, and most of them are related to funding. For our enrollment barriers, one of our issues is that the coordinator and the on-site market are only available for 1 day a week, so if patients can't come in on a Friday, then we can't really enroll them. And another thing is that just transportation to and from for the market is always an issue in Detroit, so that's been an enrollment for people actually completing the program. And then one of our biggest things that we're trying to overcome that we're spending a little extra effort on this year is actually maintaining engagement so that patients return for that 12-week follow-up. Because in the medical field, numbers are important. So if we show that weight loss and improvement in blood pressure, hopefully that'll give us some more funding as well in the future. For our future goals, we do want to partner with some other programs, and this year we partnered with a cardiology program for postpartum women to help them lose weight, especially if they've developed any heart problems while they were pregnant. We have some potential partnerships with the bariatric surgery program and the orthopedic surgery program. They all have procedures or surgeries that hinge on certain BMI requirements. And then we also are looking towards expanding the program in the number of sessions and the length of the intervention as well. We're trying to improve that 12-week follow-up to get more robust biometric data, and our end result, hopefully one day, would be to advocate for insurance support for the program as a preventative health measure. So thank you.
Thank you, Jasmine. So I want to talk about the prescription for produce program through McLaren. I am a contracted nutritionist working for them on this excellent program. Really excited to share with you where it came from, where it's at right now, and where we hope to take it in the future. So now the program's goals are to improve the outcomes of program participants determined by their attitudes about healthy eatings and their food consumption of fruits and vegetables daily. We focus on enrolling individuals who rely on food benefits and hope to empower those participants to purchase and prepare seasonal produce from local farmers, and in that provide an economic benefit to our local farmers. Target audience: McLaren, Northern Michigan primarily serves Emmett, Sheboygan, Charlevoix, and Otsego counties. We focus on pre-screening with their insurance provider. Primary care providers and physicians identify a need for nutrition education or enhanced nutrition, overall nutrition. And currently we have referrals from Alcona Health Centers, Bay OBGYN, the Health Department of Northern Michigan, Little Traverse Bay Bands of Odawa Indians Health Clinic, and McLaren affiliated primary care providers. How it works. So the participants are referred for the program. They pre-assessment of where they're at as far as their attitude towards healthy eating and their number of vegetables and fruits consumed in a day is complete for our initial screening data. They come to the program for 2 3-hour sessions on consecutive Fridays. It's 1.5-hour cooking demonstration, hands-on, and nutrition and education is infused throughout. Half-hour to shop at the farmer's market, so we go over together. Get to answer questions about the weird vegetables and those sorts of things. What do you do with this? The classes are free of charge. Participants receive $16 worth of vouchers to shop, so $48 throughout the 3 Fridays. There is childcare also that is provided, so that's not there. Classes take place at the Crooked Tree Arts Center Community Kitchen, and at the end of the 3 sessions, participants receive a kitchen kit. So they get cutting boards, knives, veggie scrubbers, peelers, there's a steamer basket in there. And the farmers at the market are reimbursed weekly for the produce that they sell. So picture of 2 weeks ago class. We also have community volunteers that come in and help during the class cleaning and moving things along, which is just absolutely wonderful. The program partners are Bay OBGYN, Bliss Garden and Community Kitchen, Crooked Tree Arts Center, Farmers and Artisan Market, Little Traverse Bay Band of Odawa Indians, Groundwork Center for Resilient Communities, Health Department of Northern Michigan, McLaren Northern Michigan, Petoskey Harbor Springs Community Foundation, and the YMCA. Started as a pilot program. Mary Rappin from Bliss Garden Farms and Community Kitchen came to this conference 3 years ago, and this was the inspiration. She brought it back to the community, took it to the Petoskey Harbor Springs Community Foundation, acquired funding, got the team together, and we're rolling into our 2nd year now. Well, our 1st year pilot program actually ended yesterday, so we had a class yesterday morning, and it's been really just an amazing thing to be a part of and really watch get off the ground. So 12 participants attended the class. The referrals, 58% came from the health department, 33% from Bay OBGYN, and 8% came essentially from word of mouth. Tell your friends it's great. And we really need and want that. So program outcomes, 80% of the participants used the food benefits, 58% used the child care that was available, 54% responded to that the program helped them feel more confident about eating and cooking fresh produce. Confidence was a big factor, particularly in shopping at the farmer's market. People were nervous about it, and they didn't want to go, and they didn't really know how to do it. So we walked them through how to do that. It made a big difference. Average fruits and vegetable consumption in a day increased. Some of the feedback we got, roommate and I now buy fresh fruits and vegetables weekly to share, learning new ways to cook, bringing home information for the kids, particularly in our first class, the amount of young mothers who didn't want their children to grow up not having cooking skills like they had done. And they wanted to change that, and that was really wonderful to hear. So they're gonna be showing their children how to do it differently than maybe they had learned. So $456 went back to the farmers, about $65 per vendor. So what we learned from last fall is we needed a longer time in the classroom. The sessions that we ran fall of 2018 were 45 minutes long, and it was a whirlwind. But also in some ways a great gift, because one thing that I hear as a nutritionist and dietitian all the time is I don't have time to do that. I can't do that, there's no time. So the 45-minute class really forced us to put together something that could be done quickly. We focused on techniques, not so much recipes. You know, this is a technique that we do. This is what you need to prepare this quickly. You can use any vegetable, any produce with this technique. So it flexed with the seasons. You know, when you go to the farmer's market with a recipe in hand, sometimes you leave and you have to go to the supermarket because that wasn't available when you got there. So we left it just sort of open, very quick, but longer class times. Now we're doing a 2-hour class, more time to spend with people at the farmer's market, more time with a nutrition focus. So expanding our referral pool and holding classes earlier in the year. Our last class last year, we used celeriac. That's what we had. So we got to learn how to cut through that, and we roasted it. It was really delicious, but you know, it was sort of interesting. And we had to bring in produce boxes from another farmer because there really just wasn't a whole lot left for them to purchase at the market. So some of the stories, Brussels sprouts up here, because we live in a small community, so it's not uncommon for me to run into class participants, and they love to share what they're doing. They love to share what's happening. I go through a line at one of the stores I go to, and the young lady that checks me out loves to tell me what she's made. You know, what the new vegetable was that she tried that week, and so that's really, it's rewarding for me. And she really loves to share it, and that I think is so valuable. Groundworks put on, could you explain a little bit how the pop-up farmers markets came about?
Yeah, so the Health Department of Northwest Michigan got a USDA Farm to School Planning Grant, and within that, Groundwork was able to be a subcontractor to put in place a pop-up farmers market at each of the 4 elementary schools in the Petoskey Public School System. And so we had at least 1, if not 2 farmers set up at each elementary school, and then volunteers like Nina who helped to implement a tasting of cherry tomatoes of a local farmer, from a local farmer. And so then they did a voting.
Yeah, I think Casey was downstairs doing it with wild rice.
They did a Manoma tasting this morning.
Yeah. So that I'm there doing the pop-up farmers market, and one of the participants from last fall came through with her whole family, and you know, was really just excited to share about their new Brussels sprouts. And just the children loved it, and she referred to her husband and said he even eats them, and yes, he really liked them, but he hadn't eaten Brussels sprouts before. So that was a great story there. Yesterday, one of the farmers, because I shot before the class, ran up to me with a turnip and said, they have to try this today. So that's really great that the farmers want to be involved. They want their vegetables to shine. They want to share what's really available. And another farmer shared with me afterwards that a mother and daughter were shopping, and they were saying, oh, well, if we get purple, we'll have all of the colors. And so, I like to really put that eat the rainbow in. So if they had the purple, they were gonna get all of their colors. So in years 2 and 3, the program has been funded by the Michigan Health Fund collaborative grant with Groundwork Center for Resilient Communities. McLaren is a sub-grantee. And the goals remain the same. We wanna focus on individuals using food benefits, empower them to purchase and prepare seasonal local foods, and provide an economic benefit to our farmers. So, thank you.
Thank you. So I'm going to talk to you a little bit about our Family Kitchen RX program. And this is under our culinary medicine program at Spectrum Health. And as you heard Jen say, I'm the dietitian for that. We have a huge need in Kent County, and that is where our target population is for our program. And in Kent County, we have almost a quarter of our children in Kent County that are at risk for obesity or already in that obesity category. And we have a huge issue with food security as well that just kind of keeps growing, and we're seeing that a lot with our families in the program. So with our Family Kitchen RX program, our goals are really to try to reach those underserved pediatric patients and their families, and start to bring down, of course, that obesity risk that coincides with our huge healthcare costs. So our purpose was to implement a family culinary medicine program where we wanted to offer hands-on cooking in the kitchen as a family together, virtual coaching from a dietitian, which is a really new piece for us at Spectrum, and then access to fresh and healthy ingredients, especially for those folks that are in areas where it's a food desert, and we have a lot of those areas in Kent County, especially in Grand Rapids. So it's a doctor prescribed program. I know Christy said she's from Spectrum, and she's our lead physician on culinary medicine. And it's funded through the Michigan Health Endowment Fund, and we get 2 years, and that started in May. And so we hit the ground running and started planning for this fantastic program. And our aim is to reach 130 to 170 youth as part of this program. We use BMI for 85th percentile or above as one of our screening criteria. They must be between the ages of 8 and 17, and then also families must speak English at this time because we just don't have our program developed out to offer in multiple languages. It's our hope in the future, but right now that's one of the criteria. So just as an overview, so we got our grant in May, our award, and we started our classes, our first cohort in January. And we went live with that. We had 2 groups that ran at the same time. We also have 6 other dietitians besides myself that help us on this grant and lead these cohorts with me. I could never ever do all of this by myself. So we're really fortunate that we had a partnership with our medical nutrition therapy department at Spectrum Health to allocate some of these dietitians to help us move all these cohorts through. So our programming, as I mentioned before, includes that hands-on teaching kitchen experience. And we do a 2-hour class in the teaching kitchen, very similar to what you're talking about, Nina, where that 2 hours is definitely needed to offer that education piece alongside that hands-on cooking piece as well. So we do provide transportation to classes. That's one of those barriers that we knew up front we wanted to try to remove so that we could get these families into the kitchen, because that usually is a huge concern for a lot of these families. And I'll go into that a little bit. We also use our My Health portal at Spectrum Health, And that's how the RD is able to communicate with the patients and their families by messaging with them back and forth. And then we're also using the Spectrum Health Now program for our virtual visits, so that we do that kind of face-to-face virtual visit with them. It makes it a lot easier for them to engage with us. So we also do a pre and post assessment of diet quality. We have a survey that we send out, the RD sends out to their My Health portal. They do that digitally through there. And then we also, of course, are looking at BMI as one of our measurements. When they come to class, that first class, we do a measurement of their BMI, and then we're also looking at dietary behaviors, and that's a big part of our survey that we send out to their My Health, looking not only at diet quality, but what is behavior like in the home surrounding meal times, and are there distractions, and are there devices being used, all of that that goes into that. So this is just really a layout of what our 12-week program looks like. So we start with that RD intake where we're reaching out to the families and we're doing engagement through that My Health portal. We're scheduling a virtual visit as well to do that initial goal setting time with the families. See what's important to them, what it is they hope to get out of the program. Just kind of find out where they are on that scale of readiness to change, because we know that's so important, and really having them captive and what is important to them that we can address. So we get them in the teaching kitchen for their first class where we provide education. It's also with a chef, and we have a lead chef on our program of culinary medicine, and we also have a partnership with Grand Rapids Community College Culinary Institute, where we also use their culinary assistants in our classes. They also teach some of the classes, and they're there also to assist and teach folks different techniques in the kitchen as well. And then in those in-between weeks, you'll see we have kind of week 2 is a teaching kitchen, and then we're doing virtual. And that's how the program goes throughout that 12 weeks. So in that first 6 weeks, 3 classes every other week, and then in between, that dietitian is engaging with the family, engaging with the patient virtually through My Health with messaging. Also, sometimes phone calls. We do have some clinics that are outside Spectrum Health that we've onboarded as this grant has been continuing to go on. And so some of those folks don't have that My Health portal. So in that case, we use secure emails and phone calls. So we get to that 6-week point, and we have a little bit of a break before we bring them back to the teaching kitchen for what we call a booster class, a refresher class for them, and get them back in there and see how things have been going after that time where they weren't seeing us every other week. During that time, the dietitian is still having engagement through the My Health portal and scheduling video visits for those folks that are still able to work that into their schedule during that time. So there's constant engagement and coaching going on throughout the 12 weeks. So this is just a look at some of our topics and some of the things that we offer as part of the classes. So in our first class, we do an introductory class, and our whole program is based off the Mediterranean diet as a foundation. So we really start with an introduction to that in that first class, and then we provide a Meijer gift card to them as an incentive, and they get a swag bag with useful kitchen items, very similar to what you're speaking to, Nina. They get cutting boards and measuring cups, all that kind of stuff in their swag bag. In class 2, we do healthy breakfast and label reading, and they also get another Meijer gift card. We get mason jar pourable lids because we do overnight oats in that class. They get to kind of take it home in a jar. So we provide them with another lid that they can use that jar to make salad dressing in, and that's something that we speak to in that first class. So trying to just really provide them with things to keep this going at home and keep them engaged at home. And then we also partner with YMCA's Veggie Van, and at class 3 we bring a bag of groceries for one of the recipes that is made in the class. So then that family can go home and they can make that entire meal for their family. And our demo, or our booster class, we do an incentive during the entire 12 weeks. We have a checklist that we start with class 1, and this is something we've implemented as we've gone on and tried to continue getting engagement with the dietitian and keep that motivation going. So you notice some folks were falling off, so we did a checklist. If they complete their checklist, they get an extra prize at the end at that booster class at that 12th week. So our virtual coaching, I spoke a little bit about this already. It's through our My Health portal and our Spectrum Health Now app. And one thing that's really cool is that we can also do blast messaging or bulk messaging out to all the members in that cohort. And in between those kitchen sessions, we're always giving them something to work on, a challenge. So we had the breakfast class, we say, show us a photo, maybe more than one photo, hopefully, but show us some photos that you made some healthy breakfast. There's something that you learned from that class. So it's really that teach back moment that we're looking for with our families, and just really seeing what they're doing at home. And we see some really awesome things at home that they're doing and creating on their own, which is, as a dietitian, fantastic to be able to actually see what people are eating at home instead of, them telling us what they think we want to hear. So our current status right now, we've onboarded 13 clinics, and it's grown since we started. A lot of people just word of mouth, hearing what we're doing on other clinics and going, I got families that I can send to you. So we just quickly onboard them, and always looking to get kids in our kitchen. So 77 patients are enrolled. We've had 48 patients graduate so far. We'll be continuing the program through May of 2020, and then we'll have some data to show after that. I have that for you today. So, but we're working on that. We just kind of started that. So barriers and challenges that we're experiencing, of course, is transportation. So I said I would speak a little bit about this. So we use Uber. We have a business account set up for Uber, and those folks that need transportation, we provide that to them free of charge. We also will pay for them to take the bus if that's what they choose, and then we also pay for their parking if they drive. Still an issue though, because some folks in our outlying areas may not have a car and Uber doesn't go there, so we do still have some of those challenges. And then of course conflicting schedules. Readiness to change is always an issue, so we try always to educate our physicians that are referring and really try to assess that level that the patient and the family is at. And then of course that the programming is in English only is another barrier as well. So these are just some fun photos of our families and kids in the kitchen, and we hear really cool things from these families, and seeing these kids come into class like, I hate fish, I'm not having fish. And they get put on the fish station that night. I don't like that fish, but I don't like fish, but I like that fish. And so this has been really awesome. We actually even had extra fish left over one night, and that kiddo took it home, and he was like raising it above his head. I can't wait to eat this tomorrow. So really cool to see. A lot of the kids just really get sad at the end, actually, because they want it to keep going. And it's just really, really fantastic to see that change over that 12 weeks of them, trying all these new foods, and mom and dad are right there with them, ready to make those changes too, which I think is super important, getting that entire family engaged. So, yeah, that's all. Thank you.
I'm honored to represent the UP. So, I have no disclosure to and so our story actually starts 7 hours north of here. So we are up in the Michigan Upper Peninsula there, and our community is considered low access, low income by the USDA. Our median income is below state and national levels, which is pretty consistent with many rural communities. And we have about 2/3 of our adults are considered overweight or obese. And I'm sure you all are quite aware of the state of health in the United States. And so I think that these programs are really one of the solutions that we need to consider when we're looking at how we're going to address the chronic disease burden in the United States. And so I'm sure many of you have seen this before, but truly 7 out of 10 deaths in the US are caused by chronic disease. And so these types of events, programs, conferences, getting people together interdisciplinarily are really, in my mind, part of the solution. And so when we look at my community and our nutritional status and food security in the US, only 1 in 10 adults eat the recommended amount of fruits and vegetables daily. We talked about food insecurity last night. 1 in 8 people in the US struggle with hunger. 1 in 6 children in the US struggle with hunger. And in my community, 18% of the population are considered food insecure. And so as a young family physician working in an underserved community, I became quickly aware of the limitations of my training, but also the limitations of the system to try to address these chronic diseases. And so kind of the eat less, move more paradigm really just doesn't seem to be working. And so I started looking at what are other opportunities that I can learn about to try to address chronic disease. And some of those, patient factors, food access, food literacy, cooking skills, these are all really important factors when we're looking at how people can make lifestyle modifications and behavior changes. And also there are a lot on the provider end too, and I'm sure other providers in the room here can agree with that. And so I looked for opportunities, and I came to the 2016 Farms Food and Health Conference, my brother-in-law, and I was just completely inspired. I came here and was blown away by an opportunity to bring all of these wonderful people to the table, all with a passion to really make a difference, and coming at it all from our individual silos, right? But now we're kind of together at the table, and so while I was here, learned about the Prescription for Health program that was started at Washington County Public Health. And at the time, they were just coming out with their implementation guide. So for any communities here that are interested in starting a program from scratch, there is an amazing free toolkit online created by the Prescription for Health program at Washington County. And so I was able to take that information and kind of get a program going in my community. And so the program details, my program was a collaboration between Upper Great Lakes Family Health Center, which is a federally qualified health center where my family medicine practice was, and our downtown Houghton Farmers Market. And so it was a 10-week pilot for fruit and vegetable prescriptions. The goal really of this program was just to increase access to produce, to fresh produce to our program participants. When we look at the eligibility requirements for the program, I limited it at this point to adults within my practice, mainly because in my community I saw mostly adults. Most of the children in my community tended to see the pediatrician, so I was trying to kind of tap into the patients that I saw most frequently. They had to have at least one chronic disease that was documented, which most often hypertension, diabetes, overweight, and or obesity were also included as possible criterion. Additionally, they had to, in the enrollment survey, express that they wanted to try to increase their fruit and vegetable consumption, and also that they had the ability to attend the market for a 10-week program duration. And so in our rural area, we have in my practice, I would serve patients from actually 4 counties, and so we really were trying to target people that lived pretty much in the Houghton-Hancock area, so that they could actually get to the market, so they could see the benefit of the program. And the pilot program was funded by the Portage Health Foundation. And so as far as our intervention, 3 tiers. So we provided produce vouchers, and participants were able to receive $10 a week in vouchers for weeks 1 through 5, and then $20 per week for weeks 6 through 10. And with the vouchers, they also received nutritional education, and so we were able to have a community health worker involved in this program, and so she was at the market. She was our person that was able to distribute the tokens, and also provided weekly seasonal recipes. So we tried to line up our recipes with what was available at the market that week, as well as educational handouts. We looked at shopping on a budget, looking at produce storage, we gave the Dirty Dozen Clean 15 handouts from EWG, and then also our community health worker was able to help our participants set one health goal each week, was able to kind of give them some additional tips on how they could reach that goal, and then when they came back the next week for the program, they checked in with them to see how they did, were they successful in reaching that goal, what were some of the barriers or limitations. And so with the program, we did do enrollment and closing sessions. So in order to, in these sessions, we were able to, the patients were able to complete free pre and post program health screenings. So we were assessing their weight and BMI at the beginning and end of the program, and we also measured their blood pressure at that enrollment session and then at our closing session. Unlike some of the other programs here where they have kind of rolling enrollment, we just had limited resources, so it was one day that they would come to do the enrollment and one day that we would have for our closing session. And then additionally, we were able to collect data from their pre and post program surveys. So we were looking at dietary patterns, fruit and vegetable intake, food and nutrition literacy, as well as health status with what's called the Promise 10 tool. And so, in case you're not familiar with this tool, it's an NIH validated tool to assess overall health status, quality of life, physical, mental health, basically ability to carry out social activities and roles. And so I wanted an opportunity for us to actually measure some of these things in our patients, because we know intuitively that when we give people access to fresh, healthy food, we're improving things more than just blood pressure, weight, right? There's much more to our health than just those biometric factors. And so with the program, we did have funding to enroll up to 50 patients. I was able to get 33 of my patients enrolled in the program. And as far as completion, 21 participants did complete the program. And the criteria for completion were that they had to attend the enrollment session, attend the closing session, and come to at least one market during the 10-week duration. And so we had a 64% program completion rate among our enrolled participants, and which I really thought was great. The majority of the participants who completed the program attended all 10 market weeks, and that was really exciting to me. We did offer incentives, which I forgot to put up here after you were talking about that. And so our local health fitness facility that's owned by the hospital donated 2 6-month passes. So those were one of the items that would be raffled off to participants that attended all 10 weeks. And then we also gave a $250 gift card to our grocery store. And so those were some pretty high ticket items. And so I think that really helped as far as our retention. And overall, the mean market visits per program participant, so of the whole 33 participants that were in the program, they attended 8 out of 10 markets, which is really great. And that also is in alignment with our voucher redemption rate. So the people that were going to the market, they were using all of the money that they were given, which is awesome. And then we were able to put in $3,684 in voucher sales into our small farmers market. So when you think about the money that's spent locally and the impact that has within our economy and supporting our local agricultural community, these programs really do pay off. Like I said last night, it's a win-win-win. When we look at program demographics, the majority of the participants were female in my program. That's mostly who I serve. Also, age-wise, the largest group was over 60. And as far as, let's see, got cut off at the bottom. But we had a pretty good, I guess, spread as far as income. Income was not a requirement because, as we mentioned, the majority of adults in the U.S. do not get enough fruits and vegetables, and so we wanted to try to offer this program to anyone that was interested in getting, more fruits and vegetables in their diet. So, as far as feedback goes, you can kind of read some of these. These were some of the subjective write-ins on the surveys. I love this one, cooking with kale. Never ate that before, so I think and then healthy behaviors. I feel more alert, I'm eating healthy, walking more, moderating influence on my mental health conditions. And so, we talked about that last night with Dr. Ramsey. So, as far as the biometric data, we were able to do some analysis on the pre and post program. Overall, BMI and weight didn't change statistically significantly in this small group, in this small program. But interestingly, the blood pressure went up a little bit, which it's kind of hard to make too much of that. It's just 2 readings, it's a small sample size. And then this phenomenon has been reported in other similar programs out there. But as far as, looking at fruit and vegetable intake, that did not change statistically significantly, but there was a slight increase, which I feel is still clinically relevant. Knowledge of cooking fruits and vegetables stayed about the same, but at the bottom, it's you should be able to see knowledge of storage of fruits and vegetables, and that actually did see a statistically significant improvement. So I think when you do give people, handouts and education with the access to the foods, it really does make a difference in their overall knowledge. But the big finding from the program in my mind was that there was a statistically significant improvement in quality of life. And like, isn't that the thing we're trying to improve in everybody? And so in 10 weeks with 33 people, by giving them $10 a week, they're having an improvement in their quality of life. And for me, that was the biggest takeaway, and actually the thing that really changed my trajectory in the work that I do now. And so the other, I have to kind of skip these then, we're out of time, but the other thing I should mention is that family members that were in this program, they really were excited to be out in the community. They were excited to be at the market, and so there was this social connection piece that people were getting. So there are other factors that we didn't measure. So, the benefits of these programs are really cumulative. And so I'll skip over that, but basically like kind of where we are today and the work that we're doing in this space between health systems and food systems, it's very innovative. It's where progress and transformation are really taking place. So thank you for your time, and I do want to give one quick shout out to our timekeeper, Carly, because she is actually the student that helped me on this program. So she had finished her, please, give her an applause. She was finishing her undergraduate at Michigan Tech in engineering, and she had an interest in health and was looking at going to medical school, and so she was able to help me with this program. She got in and did a lot of the statistical analysis, helped me with the manuscript development, and now she is a second-year medical student at Central. So these programs help to connect, students and the next generation of doctors that are coming in, into this work. So, yeah, great job.
So I am the coordinator of Shape Up North here at Munson Medical Center through our Munson Community Health. And we did the fruit and vegetable prescription program. And my presentation will be a little different than the rest. We've done, we're on our 4th grant round in 5 years. And so I've got really 3 different grants that I'm gonna go through kind of quickly. And what I'll do is really highlight some of the things that make what we've done a little different than what you've heard so far, so that we're not hearing more repetitive. Although I will say that the Farms Food and Health in 2014 that was done here, we had the prescription for health came up as well. And that's where we were really inspired and the wheels started turning of what we could do here in Traverse City and in our surrounding areas to do a similar program. So we asked ourselves some questions, what can be done to impact obesity in this region? Where has there been success? And how can we translate those successful programs that are downstate to rural northern Michigan? So again, that's where we looked at that evidence-based Washtenaw County Public Health, the prescription for health. Amazing help from them, really great guidance. You can call them and ask them lots of great questions. But it really creates that accountability between physicians and patients, which is really what we're aiming for, is to be a program that physicians can refer into. We can spend the time and help them with that nutritional information and talk with them about good food choices, introduce them to the farmer's market, and then they go back to the doctor and have that baseline to be able to continue that and help them to become healthier. And whether it's weight loss or managing chronic disease. The nutritional education and cooking demonstrations, which we've heard, and then offering solutions to barriers, which was great. Again, a lot of that is transportation. It's interesting to see that there's just a lot of folks that's a challenge for them. And again, in a rural area, they're coming from long distances. And then really the big part for us was collaboration, and how can we look at partners in our area that are doing things really well, that we can partner with them and make a really great program. So I've got a short video that I'm going to show you that gives you a little more information on what we do.
The Fruit and Vegetable Prescription Program through Shape Up North serves patients in our community that have chronic disease and have lack of access to those fresh fruits and vegetables. So lots of health problems associated with poor nutrition. Obesity is the obvious one, and along with obesity comes high blood pressure, diabetes, high cholesterol, energy level, sleep. I think all those things are affected by your nutrition. Multiple benefits of this program, which can be lifelong. Not only learning more about the fruits and vegetables, learning how to shop, how to grow these foods. I think gardening is a big part of this as well.
Participants on the fruit and vegetable program bring us a voucher, usually a $5 voucher, and then they can purchase a plant that will produce edible produce. They can take it home. We give them instructions on how to grow the plant. The participants are using products that they've never even imagined using before because they never knew how to prepare it. But now with the classes, they can prepare it, they get some ideas, and then we give them also suggestions on how to grow it, so you can grow it, cook it.
You give a man a fish, they can eat for a day. You teach them how to fish, they can eat for a lifetime.
You're going to get lots of great ideas of how to increase your fruit and vegetable intake, not only in breakfast, lunch, and dinner, but in your snacks and everywhere because you love the way it tastes so much. Your fruit and vegetable coupon gets you the fruits and vegetables of the market, but it also gets you seedlings.
The Fresh Fruit and Vegetable Prescription Program is about teaching the community ways to adopt new lifestyles that will keep them healthier and future generations healthier for years to come.
Just gives you a little walkthrough at our market. So, like I mentioned, we have a couple of different grants that we worked with. The first was Michigan Health and Human Services, the 4x4 grant. That's where we started out after we heard about the program through Farms, Food, and Health. In 2016, we started with our pilot program at Munson Family Practice, so that is a residency program. So on top of impacting patients and physicians, we impacted residents who then are out in our communities now in northern Michigan and really excited about talking with these types of things with their patients as well. So you can see we had a number, we increased the provider offices each year. To the end we had 3, all 3 are considered lower income offices. And so we really focused on those types of practices. And over the 3 years, we had, it was 16, 17, 18, yeah, 3 years, we had 464 participants. So we really focused on those patients with chronic disease coming down to the market. And as we increased the offices and saw so many folks come through, the great thing was, from a community health perspective, is we did these classes and anybody could come. So the markets really started advertising those in the community so that other folks from the community that maybe were not referred through the program could still come and get that great education and walk away with some new information as well as recipes for some of the fruits and vegetables they could purchase there at the market. The things that we looked at through our self-reported pre- and post-program survey assessments, again, we looked at food insecurity, fruit and vegetable intake, self-reported health, and motivation for increasing fruit and vegetable. A couple other things we looked at was the token redemptions and the visits to the market. These are just a couple of highlights from the program results because we did, each year we have pretty comprehensive outcomes through that. But we did see that a majority of them did increase their fruit and vegetable intake. They also were eating more fruits and vegetables every day. And the interesting, we had 53% that had were food insecure and were skipping meals. So really large population. And then at the bottom, I think the most important one was that they increased what they felt their self-reported health was, which again is extremely important. We also, in these programs, gave them things like strainers and cutting boards. We found that people were cooking food in coffee pots. They were, they just didn't have the tools. So, how can you ask someone to cook healthy food if they don't have the things to do that? So it was interesting when you really boil it down that transportation wasn't going to be the only issue. We also did a program through the Michigan Health Endowment Fund, which, as you can see, consistently has been a really great supporter of the things we do. This looked at pediatric patients. So we looked at 4 different pediatrician offices here in our county. And over the 3 years, we ended up with 270 children that we impacted. Those folks got a little bit more money than what we did with our adults. They got about $40 per time they came because we knew we were feeding a family. It wasn't just a child. So parents would come with their kids, again, and for the nutritional education. The interesting thing that we changed through our program, we had a registered dietitian from the hospital that was doing a lot of our programs. We don't have a lot of registered dietitians in this area. They're very scarce, and when the hospitals have them, they're not really willing to share because they need them at the hospital. So what we did was we partnered with Michigan State, their extension office here, and they do SNAP education. And so you can see through some of our programs that that's kind of their patient population. So as I'm out in the community talking to different partners, they thought, gosh, you have the doctors that are bringing the patients. We have a program that we need patients for. So it was a perfect marriage. So they're down at the farmer's market providing the education through their staff education program and collecting a lot of data through that as well. So it's been a wonderful partnership and one that you probably could do in your areas as well. Again, with these children, we looked at things, food insecurity, vegetable intake, self-reported health, tokens redeemed. We just got our final report for them, and I wasn't able to get the data in, but we did see some really positive data that came out of that, and we're really excited to hopefully be able to continue that with kids. Another program we did was Rotary Charities here in Traverse City sponsored. We expanded out to Benzie County, and Benzie County is one of the most, the lowest income counties in the state. And so we really thought it would be a great program to bring up to them. We looked at there's not a lot of doctors in that area either, there's one clinic. And so we had to get creative. So we looked at a clinic, as well as we looked at Benzie Senior Resources, so that's another kind of gathering place for seniors in the area, as well as Bay Area Christian Neighbors, which is acronym BACON, and that is which I'd love to see if you like beets or something a little more vegetable friendly, but that's okay. Everybody likes bacon, right? And that is a food pantry. So we changed it up a little bit because again, in an area where there's not a lot of providers, we wanted to get really at the patients. So the most impressive thing was in 2018 when we had 87 participants that came and enrolled, and 77 of them finished all the classes. So I think it goes back to, and we talk about this all the time in my office, what was it? I think that in Benzie County, there's not a lot of social engagement for people, especially lower income. So they came and they met friends and they got to cook, and when you think about cooking, that's where you know, let's go to dinner, let's have friends over for dinner. I mean, that's like what you do with your family. So it's an interesting one that we're really excited about.
I think it was the bacon.
Or maybe lack up. Again, we looked at food insecurity, fruit vegetable intake, self-reported health, so some of the same things. Again, we saw some really great results. They were feeling more confident. You know, we did have quite a bit of food insecurity there. So again, some really great results we found. And then currently we're working on a grant through the Allen Foundation. We are working in both Benzie County and we're working in Traverse City to continue some of those programs. The great thing is when you've got multiple programs going on, which makes me sound like I'm a little crazy, is that you can work with them together and they get stronger because you've got so many things going on with them that you've got one market. And if you've got multiple programs going on, it's a great utilization of resources, really. So currently we've, again, working with Benzie. There we had 116 participants again, and we had 96 finish all of our classes. So we were really happy with how that's going. And then here in Traverse City, it's still going on. So we've continued that on a bit. So this is what we're ultimately looking for, right? We're ultimately looking for fruits and vegetables to be the prescription instead of medicine, and trying to help people to become healthier and do that in ways that don't require, that make their communities healthier and don't require them to come to the hospital. That's really what we're trying to avoid here. So I think we're done. Thank you, Alyson.
I love how we stayed on time. Thank you. Thank you for being so prepared. We have quite a while for some question and answer, so hopefully you jotted down some questions and we can just present those to the panel here. And I'm going to snap a picture of this beautiful panel while you do that. Any questions? Go ahead.
Yeah, so just two questions. Well, actually, one comment and question. I hope that you guys applied for the GUSNIP prescription grant, hopefully.
No.
I'm hoping. Oh no! I was hoping that you guys or one of you applied for it because it's the winner is going to be announced by the end of this month. It's a federal program. It'll be offered soon again next year. So look for it. It's produce prescription, the Gast Schumacher nutrition incentive program. So
Through the USDA, right?
through the USDA,
Yes,
and it's a pretty flexible funding. Michigan is partly responsible why it's there. So let's show Debbie Stefano that we're still interested. So let's apply and let's get it. So can we all promise that we're gonna apply next year?
I actually, the next time I saw that it closed, and I was like right after it closed, I looked at it and I was like, oh man,
Yeah.
I lost it. No, it's great.
Yeah, but it's a really flexible funding, so just please apply for it next year. My question is that, so I'm pretty familiar with prescription for health programs. I think my start of my work in public health was really in support for sort of government funding for prescription programs. So, and one of the things that really we're really interested in trying to figure out is that, so prescription programs tend to have like those key different components, right? The prescription or the voucher themselves, then the nutrition education, and some of the social components of the programs, right? And when we measure it, all these things that we see are sometimes positive, and sometimes we see, but of those sort of three big components, so some funders are really interested of like, how do we scale up a project with as few components as possible? So the biggest question tends to be, which one of those three big components gives a program the biggest impact with the lowest amount of resources spent, right? You're not trying to change populations, or you're not trying to change strategies, you just have to focus on a few strategies, right? Instead of 5, 3, instead of 3, 1. So my question is, of those components in your programs, what do you see as sort of the biggest opportunity for you to concentrate on? Or is there something to be said about prescription for health programs that are multi-component, and is that basically the reason why it's successful? Because there are programs out there that's just nutrition education, really good impact. There are programs out there that's just vouchers, it's really good impact too. But we really want to make sure that I learn from you, like what's the best bang for your buck, basically.
So I'll speak on just my population, because we've tried different things through our clinic with just the nutrition education. We've had physicians who do one thing at a time, or just the resources. With our Detroit population, we found that because of how many barriers they have to actually getting to the market, and the knowledge barriers that they have just related to growing up with for public school systems and having that nutrition knowledge, for us it really is that combination of things that make the program successful. So I've done in my own clinic where I've had patients keep in touch with me every month so that they can let me know how their weight loss and things are going, but they're stopped by that financial barrier. So for us, having that financial incentive is a really big part of it, and it's actually one of the things that draw patients in, and then they end up sticking around for the nutrition education aspect of it and for the social aspect. So we have our market in a little corner of the hospital, and you'll see that by the end of the market season, it's become like a hangout where everyone gets together and they build their social connections at that time. And I think that helps maintain things throughout the year, because our program runs only a couple months out of the year where we actually have the market there. So for us, just in my population specifically, I think it's the combination. I think that if we had cut any part of it out, it probably wouldn't have been as successful.
What do others think about that?
I would say, I'm going to speak as a dietitian, that's who I am at my core, but I would say, looking at our program, it's a huge program, and there are a lot of components to our program, and offering incentives has evolved over the course of our program since January, and trying to get those folks in the kitchen, and I would agree with you, like it can be a huge obstacle to have them coming to a place like that Maybe they're not in Grand Rapids, they're coming from an outlying area, but that's always a barrier. I do some other different education throughout the spectrum, and we do as our culinary medicine program where we do demos of things with sampling, and that is combined with education, that nutrition education. So it's a much, more pared down format, but I think it's still at the core, people get to taste the food, they get to try something they never tried before, and then that nutrition education is part of that. I think if it's something really simple and resources are limited, like that's one of the easiest ways to do it and to get it going and up and running and out there, right? But I do think that it is a valuable experience getting people into the kitchen, especially our families, together and doing it hands-on and learning and getting that nutrition education. But yes, it is resource intensive for sure in that format, and that is something that we're looking at as how do we scale this when the grant is done. We know we can't, continue to offer, the amount of incentives that we do currently. It's not something that's necessarily scalable, but I do think that we can offer that in a different format. Maybe not even, it doesn't even have to be as long as 12 weeks, but I do think, getting them in there and exposed, however it is, whether it's a demo or it's in the kitchen, that they're exposed and they're getting the nutrition education. The two, I feel like, have to go hand in hand. That's what I always felt as a dietitian, counseling patients and just talking to them. There was a huge piece missing that, I can, give somebody, I can even hand them a bell pepper to take home, but if they don't know what to do with it, what good am I doing, right? So that is that missing piece, I feel like, in getting that hands-on approach and really making it stick with folks. That's just what I am seeing, especially as part of this program.
I just would throw out there to think about, and I think about this a lot, and I've had a lot of input in various different ways, so I will say that too. Taking a Medicaid patient who receives Bridge dollars or SNAP dollars, and also SNAP education in 3 very separate lanes. And what if we thought about a way that we could take those patients, because really it's a circle, right? They're eating poorly, they're spending, buying things that might not be best for their health, they're not educated, and then their health costs are increasing. What if we thought about ways that we could take the Medicaid patients that are receiving those SNAP Ed and then requiring them to have some education and having some of these programs like we're talking about here to help create a healthier community, healthier folks. And I know there's a lot of downsides to that, I've heard some, but it just is a bigger thought of being able to have more people have more nutrition education and taste some of these great things that we're talking about here, so.
I think that connection that they get, sharing together in that room, sharing their stories, helping each other, what their own experiences outside of that room comes into that room, and they can really grow off that with each other. There is, I don't think, a disinterest in learning more about the nutrition. There's big words out there, they see them on the internet. They just want somebody to really give them some hands-on of what it's all about. And when we can give that personal right to them, that idea of individual education with the food right in front of them gets really enormous. And I think they take home a bigger lesson that way.
Yeah, I would agree with that, and I love that you said that, like, that they learn from each other and they share, because in our program, I'll have them send me food photos of what they're doing, and then at the next class, I'll put them up on a slide on the TV screen, have them talk about it. And then they're sharing, they start, oh, you know what, this was working for me, well, how did you do that? So they start sharing with each other and learning from each other, and that is a huge part of that, with that social aspect, for sure.
And I'd agree with everything that's shared here. At the end of our program, we had a little bit of money left over from the grant, and so we were able to host a harvest dinner. So we brought everyone that was in the program together, the farmers, as well as the foundation members together. And so we all had a local meal, and I had a panel of the participants there that could share their experience and their stories. And it was pretty powerful. I didn't have Kleenex, there were tears. I mean, I was really not prepared for it. But one of the big things.
Great impact with your foundation that donated the money.
Exactly. And the one thing that they really asked for is they said, well, could we get together more often? You know, because we only had an enrollment session and a closing session. And when they went to the market, they met one-on-one with the community health worker, but there were no group demos. There were no group cooking classes. And so they asked that if we were to continue this program and expand it to include the cooking demonstrations, but to have it as in a group setting so that they can learn from one another, they can socialize, they can connect. So I would add that. There's a question here.
I was just gonna offer, I worked with children in school gardens and teaching nutrition in kitchens, and the most effective intervention for children to teach them to eat healthily is for them to participate in the full cycle of foods, to start the seeds, to plant the seeds in the garden, to tend them, to harvest them, kind of eat them in the garden, and then cook them. And we always had a harvest dinner as part of that program. But my point, and I think the person who's currently running that is speaking this afternoon, but we always talked about working with the 5 senses, and the more senses you engage in whatever behavior modification you're trying to give, the more real estate it takes up in the brain, and the more effective it is. And I'm just going to extrapolate that works for adults as well. It works for kids, and it is beyond a doubt the most effective intervention. Is if you don't give to the 5 senses and you don't participate in the full cycle of food, you can't do a piece of it. You have to do all of it.
And could that solve the issue that schools have with school gardens, which is that no one is there in the summer? You had your classes in the summer, and you had your participants helping to keep the garden going after the students planted it, and then they come back and there's
talk about it. Yeah, lots of through working many school gardens about what kind of infrastructure needs to be in place, what kind of curriculum support is in place.
Any
I have a little
response to that?
perspective. I run a horticulture program in Detroit that we're actually one of the largest farm-to-school programs in the country. We're also part of a clinic farm-to-patient program along with partners Buckets of Rain from this area. Some of you may know Buckets of Rain and Chris Gallinger. He runs a large urban farm down in Highland Park, and we're partners with the Say Clinic and the Huda Clinic, underwritten by the Detroit Rescue Mission Ministries, as well as Wayne County Metropolitan Community Action Agency. I think the important thing and the success of any program is not only the continuum of services throughout spring, summer, fall, winter, but also the partners that you bring to the table to support that effort all the way through. The way this program works is patients present with hypertension and the clinic physicians present a script, which is then taken to the Buckets of Rain farm. The farm provides them with free vegetables for a week, and that prescription is renewable week after week after week. And the results are documented as far as weight loss, blood pressure reduction, and that sort of thing. Through the winter months, the program is funded through Kroger gift cards, so we can monitor and continue to provide the access to fresh vegetables. And where I come in as an urban farmer with a large hydroponic setup, I can also supplement the produce available for these patients throughout the winter months. So to have all the aspects covered so that the patient with the educational component is covered through not only Detroit Rescue Mission Ministries, but Wayne County Metro, who provides the other continuum services, plus additional services through Wayne Metro. So not only do you have the educational component with the benefit of food, but if someone needs social services, Wayne Metro is there. Someone needs additional food relief, the Rescue Mission Ministry is there. So the outreach is there to provide kind of like an umbrella for all the patients.
That's awesome.
I see a question here.
Sort of going off of what he was saying a little bit, but what are you guys doing to ensure that your program participants are still able to continue when they, after the program completion, when those incentives are no longer available to them, when they no longer have the free transportation or the gift cards to use and the extra additional dollars? How are you able to support them in that after they continue, or after they complete the program?
So we are also partnered with our community food club, which is a really fantastic program that they developed in Grand Rapids. It's right in downtown Grand Rapids, and the RDs identify as part of the pre and post surveys that we do if they have issues getting access to fresh produce, and of course, depending on what their income level is, then they can be eligible for the community food club. And it's really kind of like a warehouse format where they pay in $10 and they get a point system. So they can go, as many times as they want during the month and get fresh produce and other items that are there. And so that's one way that they can continue to have access. So we link them up because Community Food Club doesn't just accept anybody that can come walking in just because their resources are limited as well. But so that's, if we identify that, then they're able to be supported with that. And then also at the end of that 12 weeks, we give them resources for Michigan State Extension, which also offers a lot of free programs in our area that continue nutrition education, continue even some farmers market programs as well. And so we link them up with those resources to keep that going. But it is something that we're looking at as a more robust way to keep supporting those folks, because we do hear that from families, for sure. That is a question when we are nearing the end of that, yeah.
I guess I would say for me, I'm looking at changing habits. And I look at our program as we're giving them the tools and the information to do that. And I will say the hope is that when they go back to their doctors, that then the doctors are reinforcing that. And whether they're buying their food or they're getting their food at a pantry or they're going to a grocery store, wherever that is, that they're making healthier choices and they're buying a peach instead of a can of peaches, or so that's, really it's to change those habits. So
The issue is there are no fresh vegetables in the pantries. I shouldn't say no, it's very variable, and I'm working on increasing access, or just getting some fresh fruits and vegetables in the pantry. So the population that you're serving, very often, transportation issues aside, they don't have access to fruits and vegetables unless somebody is providing them. Because the pantries don't necessarily, that August and September, you get a lot of donations from farmers markets, we're pretty good. But January, it's gonna be all canned.
Amanda.
Yeah, I wanted to ask Dr. Omar, you mentioned an interest in advocating for insurance coverage for prescription for health, and I wondered if you could expand on that and maybe challenge the idea that these programs are not scalable.
So the way that we look at it, this is a preventative health program. This is something that could potentially save us money in the future on medications for blood pressure, diabetes, cancer treatments, because there are some obesity-related cancers. So what we were hoping was to get enough as far as objective data to show that people are losing weight and coming off of these medications or making improvements in lifestyle, so that insurance companies would want to invest money to make sure that patients are doing this, even if it's something like in the pre-diabetic stage, so that they don't progress, and then kind of scale it up from there. So we have just some rumblings of maybe some insurance companies who are maybe gonna take the time to listen to us, but nothing specific so far. But I know that there has been growing interest in the medical field about these preventative health programs. So that's how we spin our program. The issue with scaling up is a major issue, just because most of us are going on grants that aren't lasting forever. So if we do have these programs where we say, we're gonna expand it to a year-long program, which is one of the things that we wanted to do in our program, we need a funding source that can sustain a year-long program. Most of that stuff is insurance companies or government grants, unfortunately. We've been very lucky in that the Eastern Market has been one of our really close partners and has helped us out a lot this last year. But we don't have a sustainable income source for this program. So the way that we can make this preventative health program kind of scale and be something that is something that an insurance company would want is to engage people who have a lot more money than what we have.
We still have about 5 minutes. Yes, I have like a kind of a
two-tiered question. One is way over here. There was somebody from Michigan Department of Education here? I thought somebody said it.
Yes, me.
Oh, yeah. So I've been teaching nutrition here at NMC for 15 years, and I teach both culinary nutrition here in this room. And then I teach clinical nutrition to nursing students and PA students too. So I guess part of my passion as being a dietitian for a long time, probably longer than I care to admit now, but a really long time, is that I feel that when I get students in my class at the college level, a lot of them say, to me something about, this is really the first true nutrition education I've ever really had is here in the college, and I'm having to take this now. So part of my passion is I'm wondering with the doctors, do you see our doctors, the curriculum for physicians in medical school, are they really starting to educate doctors more in nutrition so they know about all this? Because that's been sort of something that I've been really passionate about. It's hard to collaborate effectively sometimes if they don't know what we do and who we are in programs like this. We're all talking about it now, which I think is great, but I feel like a standalone nutrition class in med school would be amazing. And from all the things I look at, I see that we kind of have either not made progress or it's slid a little bit backwards. And so for the, in high school curricula too, there's a lot of kids that come out of high school having absolutely no clue the link between the food and their health. And I get kids in my class, and I say kids lightly because I have learners of all ages, but they'll say, I have to take chemistry and physics, but there's really no sort of standalone nutritional guideline except for that, my children received 2 or 3 days of nutrition kind of tossed in by the gym teacher or in bio class, and they even had trouble seeing nutrition as a biology class. So I kind of hoping we put more like real nutrition education in med schools, but also in high school. I feel like a kid graduating at 18 should know the connection that we're all talking about here.
It's hard to understand nutrition if you don't even know what a carrot looks like. I ran into it all the
Absolutely.
time. People don't know what food looks like.
Right.
I would always bring in a whole piece of food, and I'd always be like, what's that? I'm like,
Right.
it's a carrot. Right? They've just never seen it.
Yeah, and in my internship, I did a lot of that, just showing little kids what, that corn doesn't come in a can, and they actually, to peel it off, they're very excited to see that, or that Brussels sprouts grow on a stalk. So that elementary school stuff is where I volunteer here in Traverse City at the Montessori school, and they're real into the school gardens, which is great. But what I find the most deficit is from the high school kids who come in and they're like, I'm so glad I happened to take this class. I wish everybody had to have this.
So do you want to address
So I just didn't know if we could do like from
doctors and or high school students?
We're basically doing
a
remediation because of a gap in education.
Right.
You're not I love what you're doing, but it's not really preventative, it's remediation.
I can address
we actually have a program as another arm of the Michigan Health Endowment grant that we have. We also provide culinary medicine to our residents, our medical residents, and our also cardiology fellows. So we're still trying to get the link with our med student. We have Michigan State Med School at right there across the street from Spectrum, and lots of partnerships. But so we're still trying to work on the med school. But yes, we have a fairly robust education in place with our residents and our fellows, which has been phenomenal. I'm hearing some of the same things.
I'm speaking about it at 3.
Yes, she is. Yes. So go and see her at 3 o'clock. You'll learn more about it. But yeah, we're hearing those same kind of things like, oh, I never had any of this education. This is the first time I'm ever hearing any of this, so it's so needed. Yeah, so needed.
Well, it sounds like this conversation could go on for a while.
Yeah.
So hopefully you can grab their contact information and continue the conversation with them and with each other. I want to thank our panelists again. Thank you so much.